So welcome to James Heath, who is the president of the Institute of System Biology in Seattle, and he's leading work on biotechnologies and oncologies.
Thank you, and thank you very much for having me here. Today I'm going to talk to you about using very deep data dives on many patients to identify factors that can put patients at risk for long COVID. I think all of us know what long COVID is, but I think also it applies to other long diseases. You know, I used to be proud of this slide, but after seeing Atul's talk, I feel like a failure. So I'm not going to dwell on this. So long COVID is a condition that really has almost as many symptoms as you can imagine. Like it just spreads, it has the range of chronic symptoms from neurological to respiratory to flu-like to inability to exercise, hair loss, etc. And this picture I show here, I don't know if I have a ability to point. I guess not. This picture I show here is one of our patients. Is that, can you point? Oh, does it show here? Oh, it shows here. Yeah, okay. I can't really see the screen. I'll just, okay. Is one of our patients who, after having COVID, went through having nightmares almost every night for over half a year. And he ended up having the tattoo of this beast that he saw in these nightmares on his arm. He was basically bedridden, inability to exercise, neurological issues, memory fog, etc. So this is pretty serious, and it affects a lot of people. When we look at patients that were even mild infected patients, this is pre-vaccine, so we don't know what happens post-vaccine. But, or we don't know what happens post-Delta even. I think that's all, these are all open questions. You know, 3 months out, maybe half the patients have still got chronic conditions. At 6 months out, the number maybe drops by a half, and then it slowly drops after that. There's a report I just saw from China today that they were seeing it in most of the hospitalized patients out at 2 months, 2 years. I don't know how that applies here, but in any case, the study we did was to look at patients over time. So we looked at them from diagnosis out through to recovery at about 3 months. We had a lot of patients, maybe not a lot for such a complicated disease, but it was still 300 patients from 2 independent cohorts. And we measured as many things as we possibly could, and I'll walk through what we measured, and it all turned out to be pretty valuable. And then we tried to identify risk factors for developing COVID, and then could we actually correlate all these matrices together to associate those with symptoms? And this work was published about 2 months ago in Cell. So this is the assays we did, and I'm not going to go through them in great detail. I'll just say we did whole genome, we did about 500 proteins in the plasma, 1,000 metabolites, we did single-cell RNA-seq on all the PBMCs, we did T-cell receptors, B-cell receptors, autoantibodies, HLA haplotyping, yada, 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 okay? I think when you have a data set like this, it's very unclear how you interpret one piece of this data in light of all the other data. And I will try to talk about that a little bit, but I also have put together these symbols for saying that when I make some statement, this is how we're pulling this data out. And we also had, and this is very important, you know, when we first started this study in March of 2020, no one was thinking about long COVID. Perhaps we should have been, but we weren't. And we forgot to ask the patients how they were feeling. So we actually had to go back and ask the patients how they were feeling. And we had also a comprehensive mine of their electronic health records. So this is basically the trends that we see a few months out after acute disease. So fatigue was the most common. Gastrointestinal conditions, for example, I list diarrhea here, but there's several. That was about 10% of the patients. Fatigue was, you know, as many as 40% of the patients. If you looked at hospitalized patients, the numbers are higher. they're not dramatically higher, or maybe a factor of 30% higher. You can still have long COVID symptoms if you had mild infection. And I just compare here, there's another study that's here. Questionnaires are done differently, patients are polled differently, but the trends that we found hold when you look at trends across much larger studies. Okay, and all of our patients by the time of recovery had developed protective antibodies against the virus that you could test in functional cell assays. And the level of that protection scaled with disease severity that was known. Nothing new here. When we looked at pre-existing conditions for different adverse sequelae that patients were reporting, the one that jumped out the most was type 2 diabetes. And the reason why it jumped out the most is because we had a lot of patients with type 2 diabetes. There are some other pre-existing conditions such as cardiopulmonary issues that are important, relatively few numbers of patients. There's larger studies going on now, but diabetes actually ends up explaining about 30% of the long COVID symptoms that we find. Largely respiratory viral-like symptoms and fatigue, things like this. We mined the plasma proteome and the metabolome initially to answer the question that we had been hearing from patients that they were very frustrated. They would go into their caregiver and complain about basically the chronic conditions they were having, and nothing was, and they weren't getting a response because these are vague conditions, actually very challenging to trace down. And so we began mining the plasma proteome and metabolome to see, could we actually define some of these conditions a little more quantitatively? For patients that were complaining of neurological sequelae, like memory fog and things like this, the only thing that popped out, and it popped out with very high significance, was the disrupted circadian rhythm, this is just a 2-protein panel, but they're both associated with the circadian sleep-wake cycle. For patients with respiratory viral PASC, the top things that popped out came out of metabolite analysis, and this was cortisol and cortisone. And in some ways, this is actually very suggestive of how these patients might ultimately be treated, because there's a condition called adrenal insufficiency, which is low cortisol, that has many symptoms that are shared with what the patients that had long COVID were complaining of. And one thing that you get asked when you measure low cortisol is, are the patients on steroids? Because the steroids have similar molecular structures and they can actually compete biologically for the cortisol. And it turns out, if you look at initial diagnosis and at the stage of acute disease, absolutely. But you look at recovery, there's no relationship at all between repressed cortisol levels and steroid treatment. And so this is something that's oftentimes treated in adrenal insufficiency by cortisol replacement therapy. And that's something that is being tried at some level currently with some of our colleagues. Some of the things that we did not expect to look for, but we began seeing some literature that made us think we should look for it, was the potential for the reactivation of latent viruses. So most of us in this room are positive for EBV, meaning that somewhere in B cells or somewhere it's harbored in your body. About half of us are positive for CMV. We don't have these active in our body right now, but they're there. And various conditions can reactivate these. I think oftentimes organ transplant patients will see CMV reactivated, for example. There had been some data that people with positive for EBV antibodies had a higher probability of having long COVID. And now antibodies, as you can appreciate, have a very long decay time. So if you have antibodies, it's very hard to identify where if there's an acute event that's triggering the production of those antibodies. But if you can identify the virus in the blood directly, then that has a very short half-life, and that you can associate with acute event. So the virus, very transient in the blood, so much more powerful if you can capture the virus. And so we went looking for EBV, CMV, and the SARS-CoV-2 virus in the blood, not the nose, in the blood. We don't see CMV viremia. We did see EBV, and you can see this rapid decay. So at diagnosis, a reasonable fraction of patients have EBV detectable in the blood. A week later, it's down by a factor of 5 or something. And by the time the patients have recovered, you basically can't see it. And you never see CMV. SARS-CoV-2 behaves the same way. And in fact, SARS-CoV-2 in the blood is a very, very strong predictor of death. That's been published, and we actually validated that in our own cohort. If you have a lot of that, so it's basically a surrogate in some ways for disease severity. When you look at what symptomology associates with these viruses, the thing that jumps out is neurological symptomology. And given there's been a recent connection between MS and EBV, I think there's actually a lot of reason to believe that this connection here is real. But what it suggests is that potentially using antivirals very early in the course of the disease, something that's been discussed a lot in the past month or so, may have an impact on long COVID. I'm sure it will, but you have to hit it really early, unless there's tissue resident virus that you can get at later in the disease course. And I think that that's an open question. I don't know if we know that's possible. But in any case, there's these new drugs from Pfizer, and I think Gilead has something coming out, and et cetera. And these things, in fact, we've designed a trial and just sent it in today to do antivirals early in the disease course. Autoantibodies. So I think that's one thing that has really become apparent during COVID, is that autoantibodies can very much alter a patient's basically journey through the disease. And so one might guess that they would alter your journey out of the disease as well and impact long COVID. The most dominant autoantibody signal for basically mortality is interferon, type 1 interferon. And this has been reported by a number of groups. I just have one paper here, but there's other groups, Yale and others, that have done a lot of work on this. So that's one we look for. Also, about a year and a half ago, we published a Cell paper on acute disease. And we found a pretty surprising finding to us at the time, is that we found a lot of what are called atypical memory B cells. And atypical memory B cells are B cells that develop via an extrafollicular pathway. Basically, they mature outside of B cell follicles. And their initial association in literature was with lupus. But there's been other associations since then with other disease settings, okay? But they are in there in lupus. Because of that association, we also looked for a handful of lupus antibodies that had not been really looked for too much in COVID. And these are these antibodies down here, anti-nuclear antibodies. And what we found was, I think, pretty striking. And so this plot here is a correlation where the upper left, there's two separate patient cohorts looked at here. And so the results on the right diagonal and the bottom left diagonal should, the truth should be reflected in the fact that you see similar results on both sides, which you do. The top left part, and I guess I can try to see it here. These are the protective antibodies of different isoforms against the virus. These are the autoantibodies down here. This is this mildly infected cohort from UW, from Helen Chu's program. This is our cohort. And so you can see that if you have one autoantibody, your odds of having another one are increased. If you have one protective antibody isotype, your odds of having the other ones are greatly increased. That all makes sense. But if you have high autoantibodies, it represses your level of protective antibodies. And so I don't think they don't just alter your disease course, they actually alter your protection later once you've recovered. And so for people that get severe reinfections, this may be at the heart of that. On top of that, autoantibodies tended to associate with what we refer to more or less GI-like symptoms or respiratory viral-like symptoms, not so much with neurological-like symptoms, but we're looking at a small panel of autoantibodies. At the moment, we're looking at the whole proteome-wide, but we don't have that yet, but there wasn't much associated with neurological PASC. By and large, if a patient has these autoantibodies, they have those same autoantibodies in mature IgG isotype at diagnosis. So not all patients, but most patients that have autoantibodies that are affecting their disease course, they had them before. They may have had them at subclinical levels, but they had them and they were mature. The disease was not causing them to develop autoantibodies. It may have changed the levels of them, but it didn't change the fact that they actually had these autoantibodies. And in fact, if you looked at the patients with high lupus autoantibodies, you did in fact find that they had high levels of atypical memory B cells. And there's other immunological correlates with lupus that we found. And in fact, the higher the autoantibody, the higher the atypical memory B cells. And that suggests that these autoantibodies are functional. Doesn't prove it, but it suggests that they're functional. That however they're altering your disease course, they're having a functional outcome on that disease course, and higher antibodies have a higher impact. Okay, so we did a ton of single cell analytics. I'm only going to give you a little bit of it. And I'm going to focus on CD8 T cells here. And so what you expect to happen in patients is that you would have naive cells that would be advanced into antigen-specific effector populations as you begin to learn about the virus and you develop your adaptive immunity. And then those would contract back to a memory pool as you recover. And in fact, when you look at patients, that's largely what you see. But we wanted to know the antigen specificity of the T cells. And so we worked with Adaptive Bio and identified roughly 500,000 clones of T cells that were SARS-CoV-2 specific. And then we looked for those clones in our single cell RNA-seq data, where we also had paired alpha beta chains. And then we projected them onto the 10x UMAP of the single cell transcriptome. And that's what you're seeing here. So the UMAP is shown in that picture right there. And you can see there's effectors on the right is red, and then there's naive on the blue and everything in between. And so, and I plot here for both CMV specific, because there's something interesting in that, and for the SARS-CoV-2 specific. So for most patients, what you see is that both of these will crank up as you go from initial diagnosis to acute disease, and then they'll come down. But if you develop gastrointestinal PASC, they go up at recovery, probably suggesting that there's some sort of a reservoir of the virus or some sort of lasting damage that is leading to a non-specific and maybe even a partially specific T cell pro-inflammatory reaction. And you can see that in this bottom plot here, where I show for people that have gastrointestinal PASC, initially, very, very few T cells, but at recovery, they actually have a lot of effector T cells. And almost all of the symptoms are different. So that suggests that at least this etiology, this particular aspect of long COVID, has a very different kinetics than the other aspects of long COVID. Okay, so this is a pretty interesting plot, and I think it tells you why long COVID is so challenging. So what we did is we used this massive data set we had, and we looked at these PASC factors, and there's 4. There's the autoantibodies, and we'll just loop them together. They're treated separately here, but let's just treat them as one. There's diabetes, there's EBV viremia, and the SARS-CoV-2 RNA-emia. And we said, if we look at all the proteins, all the other, the 10x data, whatever, how related are these PASC factors? And if you look at initial diagnosis, they're actually pretty related. You see a lot of bright color on that plot, especially the autoantibodies, but you even see some connections between viremia and type 2 diabetes. And that suggests that at this time, there's maybe only a handful of treatments that you would need. There's clearly different etiologies of the disease. It has different causes, but there's not like an infinite number of treatments. If you look a week later, that color has faded. Those different PASC factors are looking less and less related. And at the time of recovery, there was zero relationship between them that we can discern from this big data set. And at that point, you look at it and you say, gosh, every single patient is different. Every single patient needs a different treatment. I think it's more as if you think about a chaotic system, where if you take a whole bunch of different systems and you start them at slightly different conditions, over time, they will exponentially diverge into their destination. And that's what's happening here. It's not that you have this crazy heterogeneity, you have some heterogeneity coupled with an intrinsically chaotic system. People have different ages, they're just different people. And that's what you're seeing here. But that makes this a very challenging disease to study. It makes all chronic diseases challenging to study because I don't think that's different. Okay, so these three factors, the viremia, the RNAemia, and the type 2 diabetes, each account for about 30% of the PASC that we saw. At least one suggestion is antivirals for long COVID. That's certainly being pursued. It's been discussed in the very recent literature. The autoantibodies, especially not so much interferon alpha 2, but the lupus associated autoantibodies and those additional signatures I talked about, suggest that you could look at systemic lupus erythematosus for treatments for long COVID. And in fact, we did. And we did sort of the Adelbute thing. We have access to the whole Providence network, and we could look through that entire system and try to understand what is most commonly used for lupus and what are doctors most comfortable for. And the answer is, wait for it, hydroxychloroquine. We're not proud of that answer, but that's the answer. And in fact, if you look at hydroxychloroquine as a treatment for managing lupus, it does something. It's used in like 30,000 patients in our healthcare system for a reason, okay? And physicians are relatively comfortable using it. There is a number of other factors that we see that we can't, they're basically unresolved inflammation. And I believe that there's probably endothelial cell damage, maybe ongoing endothelial cell damage, and we see markers of that in patients. That could be leading to complement activation, likely through the lectin pathway. And I think that that's another mechanism that's very likely druggable. So an important note is that if you have your autoantibodies done by LabCorp, they're not going to give you the same answer we did, because they're going to report back for that basically 4 sigma above a 0 baseline. If you ask for quantitative titers, they'll give you back an answer like we got, but most people don't ask for that. And so typically physicians look at patients with autoantibodies, think maybe 2 out of 3 out of 100. That's true, unless you go to subclinical levels. And that's actually a much larger number. It's maybe 20% of the patients. And then finally, limitations. We only studied patients out to a few months post-diagnosis, although the Harvey cohort, the UW cohort, was at 6 months. Our study size was limited to around 300 patients, which is, for something this heterogeneous is not very many, but it was a crazy deep study. We only looked for a handful of these autoantibodies. We aren't sensitive to PASC coming from the Omicron variant, almost surely because of its different effector mechanism, it's going to have different levels and different nature of long COVID if it is associated with Omicron. I don't know. And then there's a national recovery study of which I'm leading the Pacific Northwest branch of that, which will look at 17,000 patients over 4 years. At one level, you think it's probably going to be better. At the other level, it's because it's the government, we're here to help. It might take a little longer to resolve how it can be most effective, how we can effectively treat these patients. We're all working very hard to make that time as short as possible, but it's a big, complicated study, and it's going to take a little while for it to smooth out. And with that, I want to thank my funders. I'm looking for talented postdocs. If anybody in here is a potential talented postdoc, I'm looking for you. Thank you very much. I'm happy to answer questions.
I have a fairly naive question about the tantalizing EBV association. So you see the viremia association with COVID with EBV, but do you see the same EBV viremia association with infection or vaccination? Do you know? In the sense that an active immune response just causes proliferation of the reservoir.
We looked for it in vaccination because I had the same question you did. And in fact, we had a host of patients that were either immunocompromised, like organ transplant or MS, or were healthy controls. And we looked for EBV. We did not see it with the vaccination. So that was very reassuring.
Interesting.
EBV does get reactivated in other conditions, but at least with the vaccination, it doesn't seem to.
Thank you.
Hi. Also a very naive question. I wanted to know how you could be sure that there is no confusion effects, notably with the fact that these people, in fact, and the symptoms from these people could prevail, could be here before, but just maybe a little bit amplified or even not. But in fact that they had things, I mean, for sure, the symptoms are here, but they were here a bit before. And in fact, it's not related to the COVID, in fact.
Well, we tried to be pretty careful about that, but, okay. and I'll give you a couple ways in which we accounted for that. So number one, we validated whether they were new symptoms through both questionnaires and through going to the EHR and seeing what was in physician visits post their infection. And I only reported ones that showed up in both. We also limit our analysis to patients. I tried to group symptoms together as a way of trying to make them a little more robust so that I'm not, like GI is nausea, it's diarrhea, it's gastrointestinal pain. For neurological symptoms, people are oftentimes reluctant to provide those. But if they do, I think you kind of believe it. For respiratory flu-like symptoms, they had to have 2 or more symptoms before we said it was a significant, and those 2, at least by our mining of those patients and those patients' records, were new to post-COVID. But, you know, people stuck at home for a long time, you know, the fact that they feel lethargic might, you could make lots of arguments, but it seems pretty darn real in a lot of these patients. If you see these patients, this is not a casual condition.
With the uptick in the gastrointestinal symptoms and either increase in antibodies or CMV, did you find any signatures that would show major changes in the microbiota?
No, we wanted to look for that, but at the time we started this study, it was so difficult to get into these patients because, you know, we had, our cohort was like half hospitalized, half not, but the hospitalized ones, you simply could not ask someone to go in and get microbiome. And so we couldn't get it. There have been studies about that, and I would love to see that answer plugged into a data set like this, but I don't know. I'm sure you'll see something, but I don't know what it is. There have been evidence, I think in recent papers, if someone has been reporting of long COVID symptoms like GI-like symptoms, although I'm not going to quote you the exact papers, but I have read them, and they die of something like a car wreck. So something, okay, then they do an autopsy. They have actually found viral reservoirs in the GI tract. And we did some autopsies early on where we found in the B cell follicles in the GI that there was evidence of virus as well, and it could be resident for quite some time.
Thank you, and wonderful talk. Appreciate it.
Thank you.
Thank you.
My pleasure.